My name is Stephen Parsons. I'm an obstetrician and gynecologist. I am the director of the Women's Health Network here in Grand Falls, Windsor, Newfoundland and Labrador. It is my great pleasure to introduce you today to managing obstetric emergencies in rural and remote Canada. Along with my team of colleagues and associates, we have planned for you a series of modules that will safely and effectively help you to manage the most critical obstetric emergencies that you will face in your day-to-day practice in rural and remote Canada. While the information we present today will be unique and interactive in its web hosting and various types of media, it is in no way proprietary. This information is freely available through our various sources, including the Society of Obstetricians and Gynecologists of Canada, the American College of Obstetricians and Gynecologists, courses including More OB and Also. We referenced other sources including UpToDate and even Google. The context I hope to set for you today is to provide critical information in managing obstetric emergencies to frontline healthcare providers. That means you. This could include at your institution family physicians, nurses, nursing assistants, or even paramedics. Any frontline healthcare provider that may be called upon to respond to an obstetric emergency should it present at your facility. To accomplish this goal, we will use didactic lectures, but we will also engage you in group discussion, and it is our hope that you will invite my group to come to your institution and engage in simulation exercises where we can really practice the techniques which we are about to describe today. Certainly each site will present unique circumstances related to staff mix, your local experience, geography, and other factors. Globally, we wish to discuss various important topics. First and foremost, safety in maternity care. We wish to focus on teamwork and various tools that are useful to reduce risk and errors. Then we move on to understanding management of preterm labor and delivery, as well as preterm rupture of membranes. Core to any emergency program is the management of hemorrhage. In obstetrics, hemorrhage can be catastrophic. Heavy bleeding can happen before delivery, or indeed can happen once the delivery of the baby has been completed. We will focus on emergency management of both scenarios. We will review the cardinal movements of labor and delivery. We will practice the various maneuvers that will be utilized to overcome a shoulder dystocia, should that unfortunate event occur. Finally, we will discuss key factors in effective maternal as well as neonatal resuscitation. Specifically, Miss Debbie Foswells, who is the nurse educator in obstetrics for Central Health, will discuss the issue of safety in maternity care. She will highlight various aspects regarding high reliability organizations. She will introduce you to the 2-challenge rule and other concepts. My colleague Dr. Jennifer Mercer and Dr. Robert Brooks will introduce you to the idea of preterm labor and delivery and preterm rupture of membranes. Hopefully, following our discussion, you will be more comfortable in the medical and surgical management of these issues should they occur. You will be familiar with the utility of transvaginal ultrasound for assessment of cervical length, the use of fetal fibronectin in determining which patients are lower and higher risk for a preterm delivery. You will be well versed in the utility of antenatal corticosteroids, options for tocolysis, and understand the use of magnesium sulfate in the 21st century in reducing neonatal morbidity. Regarding obstetric hemorrhage, there is a differential to understand with antepartum hemorrhage And how does a frontline healthcare provider distinguish between bleeding that may be coming from a placenta previa versus a placental abruption? Moving on to postpartum hemorrhage, we commonly refer to a concept called the 4 T's, and these include uterine tone, tissue, trauma, and thrombin. We will teach you how to distinguish bleeding that comes from each of these issues and how to appropriately manage and respond to the same. Importantly, in the management of hemorrhage, there are mechanical means, there are medical means, and there are other surgical means. We wish to highlight the importance of when is the appropriate time to arrange transfer and to where. Does that alternate center mean referral to your colleague at a secondary center, such as we have in Grand Falls, Windsor, or does that include referral to a tertiary care center, such as the Health Sciences Center in Newfoundland and Labrador? Perhaps one of the more concerning presentations for a frontline healthcare provider would be the pregnant patient that presents suddenly to your hospital or possibly in your ambulance and is clearly about to deliver her infant. And while this can seem scary, with a little preparation, certainly you can safely navigate this circumstance. Today we will review the cardinal movements of labor and delivery. We will highlight the importance of active management of the third stage of labor. We will then move on to the critical discussion of how does a physician or healthcare team safely and effectively care for 2 patients at once, as we discuss maternal resuscitation and neonatal resuscitation. Unfortunately, a small proportion of our laboring population will encounter a shoulder dystocia. Shoulder dystocia is an obstetric emergency. It can certainly evoke fear in the most seasoned healthcare professional. With preparation, one can confidently manage and effect a safe delivery of a shoulder dystocia episode. And with our module today, we will teach you the tried and true methods of which you can successfully overcome this potentially catastrophic emergency. In resuscitating a pregnant patient, one must be aware that the usual rules of basic life support, advanced cardiac life support, advanced trauma life support still apply. There are subtle differences, however, with our pregnant patients, and it must be clear that the first priority is always the mother over the baby. However, when properly applied, using those techniques and the techniques we will teach you today, you can confidently manage a situation of a maternal trauma or maternal cardiac arrest and potentially have an excellent outcome for both of your patients. The specific goal that I hope we achieve today is not only a healthy mother and baby, but a happy mother, happy family, and happy healthcare providers at having provided a job well done for your patient and your community.